Okay, so we ended up in this slide, and I was showing you the location of the different veins in our body. And one detail about most veins in comparison to arteries is that veins, since they don't have as much blood pressure, they tend to be more superficial than arteries. Arteries, they need to be internal or deep for protection, because if someone damages one artery, it cuts one of these arteries, the person will have massive bleeding, because you have increased pressure during systole, decreased pressure during diastole. Now, most veins, they have similar names or the same name as the arteries, and they are paired. So for every artery, you have two veins. And there are some exceptions to the rule. For instance, we don't have the name jugular veins. We don't have jugular arteries. We don't have carotid vein. We only have carotid arteries. The saphenous, like the greater and the lesser, they are unique names. We don't have a basilic name for an artery. We don't have cephalic name for an artery. And the hepatic portal vein, for instance, we don't have that name for an artery. So we have then few exceptions to the rule. Now, the blood from our brain is drained by these dural sinuses, and then it's drained into the internal jugular vein. And the blood from the face is drained into the external jugular vein. And the internal jugular merges or anastomoses, that's the name for merging, anastomosing, anastomoses with the subclavian vein, and they form the superior vena cava. The brachiocephalic. And then both brachiocephalic, the left and the right, merge and they form the superior vena cava. And we have this system of veins in the posterior area for thorax that are the azygous veins that drains the blood from the thorax into the superior vena cava, and everything then from diaphragm and above is drained. Every blood is drained by this superior vena cava, while everything below the diaphragm is drained into the heart by the superior vena cava. So then here we have the greater saphenous, the lesser saphenous below the knee, and then we have the popliteal here, femoral, anterior, posterior tibial, and they merge and they form the external iliac, which anastomose with the internal iliac, and then they form the common iliac. Both common iliacs drain basically the blood from the pelvic area and the lower limb, and then they merge and they form the inferior vena cava. The inferior vena cava receives the blood not only from the common iliacs, but also from all the veins that we have in the abdominal area. So we will see more details about those veins later. Okay, so now let's move into the physiology of the circulatory system, hemodynamics. So the blood goes between the systemic circuit and the pulmonary circuit because we have differences in pressure that are highest at the heart. This is called the pressure gradient. And blood pressure is a force, it's a physical force that moves the blood against the internal wall of the blood vessels. Remember, the internal wall of the blood vessels is known as endothelial membrane. And then this pressure inside the blood vessels is measured in this unit, millimeters of mercury, or mmHg. It varies depending on the cardiac cycle. So it's highest during systole, it's lowest during diastole. During systole, you have a pressure, if it's a normal adult, between 110 and 120 millimeters of mercury, and then your diastolic will be like from 70 to 80 millimeters of mercury. So the highest number usually refers to the systolic, the lowest to the diastolic. And then the ARIS, the systemic ARIS, they have basically a pressure difference from the veins. So the systemic ARIS can have 120 millimeters of mercury as the highest pressure, while the veins, they will have between 10 to 15, especially large systemic veins, like the superior and inferior vena cava. And then because of this pressure, this difference, like if you, let's say that it's 10 millimeters of mercury, like the pressure of the veins. If you subtract 10 from 120, that gives you a difference of 110 millimeters of mercury. So that difference then is what it moves the blood. And the movement of blood is called blood flow. It's the amount of blood that flows per minute and generally matches the cardiac output, which is 5 to 6 liters per minute, and it will be in the different areas of the body variable depending on the size of the arteries and as well depending on the importance of the organ. So, blood flow is directly proportional to the pressure gradient, and blood flow increases when the blood pressure increases. Something that influences the blood pressure is resistance, peripheral resistance. Basically, that's the force against the heart has to pump the blood. And velocity, it is the blood flow determined by the cross-sectional area of the blood vessel. If the blood vessel has a cross-sectional area that is wide, the blood flow decreases. So in the case of the smallest blood vessels that we have, which are the arterioles, in this case, the cross-sectional area is great, and you will have less blood flow than in the aorta, which is the largest artery that we have in our body, and this is where we have the highest blood flow. So for a single vessel, that cross-section, the diameter, basically tells you how much blood flow you will have from edge to edge. That's the diameter, that's the area. So it can be calculated multiplying pi times to the radius squared. So this is the formula for area. A equals P times R squared. So the radius is the half of the diameter. Basically, you measure from the center of the circle to the edge. So something that happens in physiology, cardiovascular physiology, is that you don't have to have a great change in the diameter to influence the velocity. Sometimes when you have a very tiny change, like reducing the diameter for a few millimeters, you can increase the blood flow so much because of this formula. Now, in the case of the aorta, it has less cross-sectional area, although it's the largest blood vessel that has the largest diameter. It has less cross-sectional area than the sum of these small blood vessels, just because we have more arterioles and they add up and then they end up like much larger than the aorta itself. So in here we have a closer look of the relationship between cross-sectional area and velocity. So in this case, we have a blood vessel with a cross-sectional area of 5 centimeters squared. So if you have small blood vessels that all together add into 10 square centimeters, because you have here 5 blood vessels, so if this large blood vessel will split into 5 small ones, that each of them will have 2 centimeters each. This cross-sectional adds up, and then this cross-sectional area will be the twice as this cross-sectional area. So then the blood as a whole, in here, the blood flow will decrease in a cross-sectional area that is larger than this. Although individually, the blood flow in this one will be greater than this. So as an example, we have here this container where you have in the area where maybe you will introduce a fluid into this container, you have 5 square centimeters. And then in this one, the ending or the exiting of this container, you have 2 square centimeters. So if you add in this case, the 5 blood vessels that we had before here, that forms 10 square centimeters as a whole, you will have a reduction in velocity. So in this case, you can divide this velocity, which is equivalent to, let's say, 10 centimeters per second. You divide it by 5, that will give you 2 centimeters per second. And now in here, where you have 10 centimeters per second and your cross-sectional area is 10 square centimeters, 10 divided by 10 will give you 1 centimeter per second. And then in the individual, like in here, in this individual blood vessels, which have a square area of 2 centimeters, if you divide 10 by 2, that will give you a flow of 5 centimeters per second. So that will be the equivalent of the largest blood vessel. So this small blood vessel as an individual will have the same diameter, the same flow as this one, as the large. And then a comparison that they give in your book is like saying, if you have basically a hose and then you're watering a garden, a flower bed, and it's during the daytime when everyone in the city is using water. You have not so much water coming from the ending of that hose. What would you do to increase the distance or the flow? Well, you obstruct the ending, right? And that increases the velocity and even the distance for traveling. So that's what you would do with these blood vessels. Out of one large blood vessel, you start subdividing into small so that you don't lose blood flow. You keep the same blood flow across these blood vessels. But eventually, the length as well will influence the blood flow. The longer the blood vessel, the less blood flow that you will have. So, factors that determines your blood pressure, your peripheral resistance, which will be the resistance that it is made by the diameter of the arterioles. We have more arterioles than arteries in our body. And this is a type of artery, actually. But if you add all of these resistance from the arterioles, it will be a huge resistance. And then you will have the heart pumping harder to overcome that resistance. Another thing that influences is the viscosity of the blood. The thicker the fluid that it is, the more force that you have to exert and the less flow that you will have. It's not the same, the force that a pump of oil has to apply to oil than a pump of water. Water is less dense than oil, so a pump of water works less harder than a pump of oil. Typically, we have, every one of us, we have normal viscosity of blood. It is not so thick. But there are some diseases that increases the number of erythrocytes, and then the person has thick blood. In Spanish, there's kind of a saying, sangre de atole. It's like basically having thick blood. And that refers sarcastically, I guess, to someone who's very calm, which is good. It's better than someone who's very stressed, from my perspective. Anyway, so yes, the viscosity affects the flow of blood. More viscous blood, less blood flow. And things that can change the viscosity of blood is not only the number of cells, but also proteins. And also the amount of water that you have in your blood. If you're dehydrated, your blood becomes more viscous. Okay? If you have greater number of proteins, your blood will be more viscous. And vice versa. If you don't have as much proteins, your blood will be very thin. And then the radius. So when your blood vessel dilates, the radius increases and the resistance decreases. So let's pretend that this spacing here between the edge of this bench and then, or this seat and this metal is the radius of a blood vessel. The narrower the blood vessel that it is, the more resistance that you will have to have, because you will have friction against this. So that decreases the blood flow. And the wider the diameter, let's say that you open up the blood vessel, the more blood flow that you have because you have less resistance. Does that make sense? Vessel length. Longer blood vessel, less blood flow. Shorter blood vessel, less blood flow. Now, once you grow and you have your specific height and your blood vessels are of a specific length, those blood vessels don't increase in length because you don't get any taller. So that can be neglected in a way. Another thing that it can happen with blood flow is that you can have what is called a laminar flow, or you can have a turbulent flow. Laminar flow is when your blood cells just go parallel to the walls of the blood vessels. And the blood cells that are basically flowing against the wall, they will have less velocity than the ones in the center. The reason for this is because you have friction of the blood cells against the wall, and that friction reduces the velocity. Then the blood cells in the center will flow without any obstructions, and they will be much faster than the ones on the periphery. You want to walk, there's a narrow path, bunch of people, and then the ones in the center, well, they will still be kind of slowed down because you still have people around you. But they will walk faster than someone who basically is walking toward the wall. Why? Because the person will be pushed against the wall, and then you will have friction. Now, if you have obstructions in the blood vessel, like plaque, you will have a turbulent flow. And that turbulent flow will make these erythrocytes to hit each other and increases the chances to form a blood clot. Turbulent blood flow is not efficient. So, well, you were in bad luck. After the concert, you have to go through this narrow hall, and then you are against the wall, right? And then you're like trying to push people so you can walk freely. But what if you have a trash can in front of you? Then you have to do this to keep on walking. And then you get in the center of your place, and that's That's nice. So then obstruction reduces the blood flow. And then when you have turbulent blood flow in certain areas, you can hear a swishing sound like shh, shh. These are called bruits. These ones especially are important in areas like the common carotid. And then it happens as we age. Some of our blood vessels become obstructed, and then we have less blood supply to the brain, and we start forgetting things and have a stroke maybe. Okay, now, when we are determining the blood pressure, we have to take into account how much blood per minute is being pumped. And this is known as cardiac output. So cardiac output is the amount of blood that our heart pumps per minute. And this, together with the peripheral resistance, will give us the pressure gradient. So in pressure gradient, we have this symbol, delta, Greek letter delta. This represents the change in pressure between the systole and diastole cycles of the heart. So if you move one of these variables, and if it's multiplying, you pass it to this side dividing. So if you want to calculate the peripheral resistance, for instance, it will give you a relationship. So for instance, we have the relationship that tells you that when cardiac output increases, your blood pressure increases. The more blood that you have, or more volume, that will increase the blood pressure, and vice versa. If you have less blood volume, your blood pressure will decrease. Isn't that what happens when someone has a hemorrhage? They have less blood in their system. So our heart will be like, well, I want to pump more, but I don't have more. And then the brain receives less blood supply. What is one of the first things that happen? Person will faint because it doesn't have enough blood supply to the brain. And then cardiac output can increase when you have your sympathetic system activated. So yeah, your blood pressure drops, you have a hemorrhage, but then your sympathetic system, your baroreceptors respond by sending signals so that you can pump harder and more times the blood, no matter that it's a very little blood that you may have, but your heart wants to compensate by increasing the number of times that it will beat. So that, together with the fainting, will put your brain at the level of the heart, and hopefully your brain receives enough blood supply, as it's the most important organ in that case. And then the opposite is true. When someone has normal levels of blood in their system, it has normal cardiac output, there is no reason to have activated sympathetic system. So in this case, you activate the parasympathetic system. That's the rest and digest system. So your parasympathetic nerves, coming specifically vagus nerve, will basically help to reduce the heart rate because you don't need as much blood supply. So another factor that determines your blood pressure, again, is blood volume and the vessel compliance. The vessel compliance is basically the property of distensibility or stretching that your veins have to hold amount of blood. The less compliant that your blood vessels are, the less blood pressure that you'll have. So this is something that happens as we age. We have decreased compliance. We may have normal blood volume, but our veins, they don't distend as well. And then we have static blood. The blood is not pumped as efficiently toward the heart. And then we end up with formation of blood clots, perhaps. Or as well, something that it happens is that we may be lying on bed, and then when we wake up, we feel a little bit dizzy. Because after you turn, if you stand up, what it's supposed to happen is you will have constriction of your veins in order to push blood towards your heart, and then your heart can pump it into the brain. But if you don't have this mechanism of basically having elastic veins that can distend and then contract, plus your muscles are weak as you age, then you don't have that mechanism normally, and then you have dizziness. So this is a summary of all these factors that determines blood pressure, your radius of your blood vessel. So here's the lumen, the central area of your blood vessels. So if it's reduced, you increase your blood pressure. If it's increased during vasodilation, you decrease your blood pressure. Viscosity. Your blood is viscous, you will have less blood flow. If it's less viscous, you will have kind of technically more blood flow, but you have actually greater chances of your erythrocytes hitting each other. And then the length, the greater the length, the less blood flow. The shorter the length, the more blood flow. Turbulent blood flow when you have obstructions. And that, all of these factors, the radius, viscosity, length, and obstructions determines peripheral resistance. Now, volume of your heart per minute, a stroke volume, your heart rate, your hydration based on gains and losses will determine the blood volume. If someone is dehydrated, how is going to be the blood volume? Low or normal? Low. Your heart rate. If you have normal volume and you increase your heart rate, like if you are doing exercise, you will have increased cardiac output. And then blood volume, the amount of blood that your heart pumps per minute, and your peripheral resistance tells whether you have a normal blood pressure or not. So, blood pressure in the pulmonary circuit is about 15 millimeters per second on average. Sorry, not per second. I was thinking volume in blood flow. It is 15 millimeters of mercury on average. So your pulmonary trunk has a pressure on average of 15 millimeters of mercury. Now, in the systemic circuit, the aorta will have an average of 95 millimeters of mercury. So between the pulmonary circuit and the systemic circuit, there is a difference, there is a gradient, and that's what it moves the blood between the two circuits. Is there a difference between them in pressure? Yes. How much is the difference? 80 millimeters of mercury. So remember the principle of physiology, that differences in pressure, in concentration, in temperature drives items from more to less. Someone who weighs 95 pounds can easily push an object that it is 15 pounds. If the person tries to push an object that it is the same weight as the person, so let's say someone weighs 95 pounds and is trying to push an object that is 95 pounds, I don't think the person will be able to move it without so much effort. So in this case, there is no gradient. But in here, we move the blood between the systemic circuit and the pulmonary circuit because of these differences. And then arterioles, they have between 80 to 35. The farther away from the heart, the lower the pressure that it will become. And look at the veins, between 5 to 0. So here we have this diagram showing you the different blood vessels in the x-axis and the pressure in millimeters of mercury in the y-axis. So we start with the aorta, and then we move into elastic arteries, muscular arteries, arterioles, capillaries, venules, veins, and vena cava. Actually, the blood will move in this direction. From the aorta goes into the elastic arteries, muscular, arterioles, capillaries. The blood from the capillaries is drained into the venules, and then into the veins, and then into the vena cava, and then the blood from the vena cava goes into where? Into the pump, into the heart. So look at the changes in pressure here in the aorta. 80 during diastole and 120 over systole. So there is this normal pulsation, up and down. Now, as we move from the aorta into elastic arteries, muscular, the pressure starts getting lower, and then the pulsations eventually doesn't happen in arterioles. Why? Because we are losing the tunica media. We're having less and less muscle. In these first arteries, we have more muscle, so that helps to distend and contract to maintain these differences in between blood pressure changes. And then we can calculate the MAP, which is the mean arterial pressure. And then this mean arterial pressure drops so much in the arterioles and become almost null at the vena cava. If someone has normal health, you can just measure systolic, diastolic, and that basically tells you part of the vital signs of the person. But sometimes some people in the hospitals, they can have changes in the systolic, diastolic constantly, and then you don't know what to write down. What is the, I mean, you will write, of course, well, this is the pressure that I found at this time. But if he has so much swings of blood pressure in the day, it is in critical care, you want to calculate your MAP, your mean arterial pressure. That tells you more. So the MAP, the mean arterial pressure, it is calculated using systolic pressure and diastolic pressure. And the difference between systolic and diastolic is called the pulse pressure. If you have 120 over 80, what is the difference? 40. That's the pulse pressure. If you have 100 over 60, what is the pulse pressure? Or 110 over 60, what will be the pulse pressure? 50. So, this is a vessel that is relaxed without blood, and once it's filled with blood, that blood exerts pressure. So, the more blood that you will have with the aid of a pump, the more that you distend this vessel. And this expansion of the lumen of these blood vessels create a sound. These sounds are called the sounds of Korthoff. These can be heard with an stethoscope. When you close up these blood vessels with an sphygmomanometer, the cuff, you inflate the cuff, that will constrict your brachial artery. You put your stethoscope, and then you will be looking in the sphygmomanometer the changes in blood pressure, and you will be listening to these sounds. And we're talking about like these blood pressure measuring devices that are not the electronic ones. So you can listen to these sounds of the blood pushing against the wall of the blood vessels. So when the left ventricle is in diastole, your blood vessels are not as distended as when you have systole. And then in your skin, you can measure the rate of expansion of these blood vessels of the arteries. We're talking about arteries. And this is called the pulse point, because you can measure the pulsation. When it goes up, every time you can feel it. So, when cardiac output increases, blood pressure increases. When blood volume increases, pressure increases. When resistance increases, blood pressure as well increases. So those are three factors that determines blood pressure. So I explained that as your arterioles receive the blood pressure decreases because they are more contracted. And then the device to measure the blood pressure is called sphygmomanometer. And then you use an stethoscope. You apply it specifically in the brachial artery. I have seen this before, thankfully only once, because, I was visiting a friend, and then someone came and tried to measure the blood pressure of the dad, and they put the cuff of the sphygmomanometer, it was an electronic one, around clothing. That's not correct. It has to be bare skin. So then the sounds of Korthoff can be heard with an stethoscope. So systolic pressure is the first sound, is loud, and it corresponds to when you look at the dial and you have like a jump in the dial as the pulsations is happening. And then you will hear a series of sounds gradually getting less loud, and the last loud sound that you hear is the diastolic pressure. So in the lab, you will be measuring your blood pressure. To calculate the MAP, the mean arterial pressure, you basically add the diastolic pressure plus 1/3 of the difference between the systolic and diastolic. So if someone has 120 over 80, the diastolic will be 80, To that 80, you have to add the difference between systolic and diastolic, which is 40. So if you divide 40 by 3, more or less, it's supposed to give you like 13. So 80 plus 13, that's 93 millimeters of mercury. That's the map for someone who has 120 over 80. And then the capillaries, they don't have more than a single layer of cells, the endothelial cells. So in there is no way that you can contract the capillaries so that you don't have this pulsation going. So in there, basically, you have very low blood pressure. But for sure, you have other forces that help for the exchange of fluids within these capillaries and also gases. So capillaries, they have two endings. One that is called the arterial end, and the other one is called venous end. The arterial end is going to be close to the arteries. The venous end is going to be close to the veins. And there is a difference in pressure. The arterial end has 35, while the venous end has 15. So it's a 20 millimeters of mercury of difference, and that will keep the blood flowing. For the systemic venous pressure, it drops up to 4 millimeters of mercury in the vena cava, but it can be as low as 0 in the right atrium. So if you start with systolic 120 in the left ventricle, and then you have 0 in the right atrium, that keeps the blood flowing. So you have 0 here, and you have 120 here. This is the aorta, this is the vena cava. So the blood goes from the left ventricle, this is LV, left ventricle, this is RA, right atrium. So you will have the blood going in this direction, going into the body, and then returning like this. Why? Well, because there is a gradient. And if you say, well, the map, well, let's say 95 millimeters of mercury is 0 in arterial pressure. Still, it's a big difference. So you keep that circulation going. Now, something that also aids in the return of blood, it is the presence of valves in the lower limb veins. So these valves prevent the backflow of blood because they are like the semilunar. They open, allow the blood to go up, and then as gravity exerts its force over the blood will tend to go down. Then that half-moon-shaped valves catches the blood, closes them, and then the blood keeps going in anterograde motion, which means going towards the heart or anteriorly. And then we have smooth muscle walls in the veins that contracts as well, helps to bring the blood up. And we have a skeletal muscle. in the calf and also in our thigh. We have powerful muscles that contracts the veins and that will push the blood at higher levels to reach the common iliacs. Not only that, but we have the respiratory pump. Every time that we inhale, we create a vacuum, a negative pressure in our thorax. That will act like a siphon, like it brings back the blood into the heart. So those 4 factors, venous valves, smooth muscle cell in the veins, the calves muscles, the thigh muscles, and the respiratory pump move the blood toward the heart. And here is this cartoon showing you the veins that we have in our leg. So here we have the gastrocnemius muscle contracting this vein, helping to move the blood above into the popliteal area. And then here we have an open valve. By gravity, again, the blood goes down, closes this valve, and that's supposed to keep the blood flowing up. The more that you're standing, sitting, the more likely that you will develop incompetence of these valves. This is called varicose veins. Why? Because your muscles are not contracting as much. And that basically makes your blood vessels to dilate, that weakens your valve. And there are genetics for that. There are some people that don't stay so much sitting, but they have family members that has varicose veins and they inherit that weakness. Another weak point for the venous system will be the veins around the anus. They can overdilate, and this is called hemorrhoids. So in order to maintain the blood flow going and then the perfusion of the tissues, you need to have a map of 95. So in order to maintain your map of 95 millimeters of mercury, you have the sympathetic system with its hormones, epinephrine and norepinephrine, that are released when you have a drop in your blood pressure. When you have epinephrine or norepinephrine, your blood vessels constrict and also your heart pumps harder and more times. So you increase contractility and you increase the heart rate. Your parasympathetic nervous system will help also to regulate this, because once you have a normal mean arterial pressure, there is no more need to activate your sympathetic system. So in this case, you normalize your blood pressure, and your vagus nerve will release acetylcholine that decreases the blood pressure and decreases the heart rate. So here is the diagram showing you the reflex that happens to maintain the blood pressure in short term. So we have baroreceptors in the aortic arch and also in the carotid, and they detect a change in blood pressure. So if your blood pressure is high, in this case this panel on the left, you will have these receptors in the baroreceptors sending a signal into the cardiovascular center through the glossopharyngeal nerve. And this will lead to, here is low blood pressure. So if you have low blood pressure, then your baroreceptors send the signal into your cardiovascular center in the medulla oblongata through the vagus nerve, and then you will activate your cardiac nerves, part of the sympathetic system, your cardiac plexus, which is going to activate the heart to increase the heart rate. And also your heart will increase the contractility, so it will beat faster. And not only your heart will respond to increase the blood pressure, but also you have the nerves that innervate this tunica media in your arteries, and your muscle cells will contract. That will decrease the diameter of the blood vessel that is called vasoconstriction, and both of them, vasoconstriction increased heart rate, which increases the cardiac output, will lead to increase in blood pressure. Now let's say that now someone has high blood pressure. Similarly, your baroreceptors in the carotid artery and your aortic arch will send a signal into the cardiovascular centers through the vagus nerve so that you will have less output from the sympathetic system. So then you will have vasodilation, and then your heart will beat less faster and less strongly. That normalizes your blood pressure. So your vagus nerve as well will decrease the heart rate, and as you can see here, you have less heartbeats than here. So everything there will help to decrease the blood pressure. So everything is between vagus nerve, cardiovascular center, and then the heart and the blood vessels, and sympathetic system, parasympathetic system. We have a specific mechanism that is called the baroreceptor reflex. So again, you have your baroreceptors in the aortic arch, which are called our aortic sinus, and the ones in the carotid sinus. And if you have increased blood pressure, your baroreceptors will fire more action potentials, and that signal will go into this control center in the medulla oblongata, and then you will activate your parasympathetic neurons so that you will decrease the heart rate and induce vasodilation by having less cardiac output. Pressure goes up, more action potentials. Pressure goes down, less action potentials, less distension of the baroreceptors. So then once you normalize your blood pressure, you don't have to send as many action potentials, so your baseline of firing returns to normal. So this is the baroreceptor reflex, response to increased blood pressure. So this is the carotid artery. This is the internal carotid. That's where we have the carotid sinus. That baroreceptor sends increased blood pressure, then sends a signal through the glossopharyngeal nerve, and then that signal is going to be more action potentials. Then your medulla oblongata sends a signal to the sympathetic system saying, well, we have high blood pressure, don't increase the blood pressure more. So the activation of the sympathetic system happens here, but at the same time you activate your vagus nerve, so you have this positive sign, meaning that you activate your vagus nerve, negative sign, meaning that you deactivate your sympathetic system, and then you have less vasoconstriction or vasodilation, and then you decrease the heart rate. That normalizes your blood pressure. So any questions about this reflex? So you can stimulate this reflex by massaging the skin over the carotid sinuses simultaneously. That can lead to a drop in the blood pressure. So that's the carotid sinus massaging. And for the decreased blood pressure, I told you before, so everything is detected by these sinuses. Glossopharyngeal nerve sends a signal into medulla oblongata, basically less firing action potentials. That sends a signal for sympathetic system to become active, vagus nerve to become inactive. Then you increase the blood pressure through increasing contractility of the heart, more times of beating, and then increase the constriction of your blood vessels. So that normalizes your blood pressure.
Question. What about people with neck damage or people with diabetes? Does it mean that they have poor baroreceptors?
That can happen. Yes. So that, I mean, if your nerves are damaged, it's like if you're trying to go from one area to another one in a highway, and that highway for some reason got damaged, you cannot go as easily as if it was the normal flow. So if the nerves are damaged, you have poor baroreceptor reflex. Good observation, good question. And some people will have something that's called a vasovagal syncope. Person can faint after receiving bad news or having extreme fear or trauma. So what happens is that your vagus nerve becomes activated, and vagus nerve decreases so much the contraction of the heart, so you have inhibition of the sympathetic system, but more activation of the parasympathetic, that decreases so much your heart rate that someone will faint. So something else that controls the blood pressure, it is actually the presence of hydrogen ions and the levels of oxygenation. So these are detected by peripheral chemoreceptors found in the same arteries, the aorta and in the carotid artery. As well, we have central chemoreceptors that are located in the medulla oblongata. When someone has high levels of CO2, that means that they will have high levels of hydrogen ions. That will stimulate your chemoreceptors, central and peripheral, so that you increase the breathing rate, so that you will exhale CO2 and then you gain oxygen. And that increases also your heart rate. And when someone has normal levels of these, oxygen and hydrogen ion, you don't need to contract the heart as much, and you don't need to breathe as much. Our endocrine system controls blood pressure through several hormones, including epinephrine, norepinephrine, and thyroid hormone. Thyroid hormone, what it does is that increases the receptors for epinephrine, norepinephrine in the heart. So someone with hyperthyroidism normally has high levels of blood pressure and also high levels of heart rate. It has tachycardia because it can bind more epinephrine and norepinephrine. So we have additional hormones like angiotensin II that is released as part of a cascade of chemical reactions that happens in our body when you have low blood pressure. And this angiotensin II vasoconstricts. So basically your blood vessels become smaller. And then we have atrial natriuretic peptide, or AMP, that decreases blood volume and at the same time decreases blood pressure. If someone has excess of blood volume, your right atrium will distend, and that releases the atrial natriuretic peptide. Then your kidneys will start eliminating more sodium, and since water follows sodium, you will eliminate water at the same time, and you will decrease blood volume. So that's short-term maintenance of the blood pressure. Now, long-term is given by the urinary system. So your urinary system acts by decreasing, increasing the elimination of water when someone has chronic high blood pressure. And your kidneys will detect the levels of oxygen and also distension. So if you have low oxygenation and if you have low blood pressure, you will release an enzyme that is called renin. And that renin is going to be part of the cascade that it is in charge of increasing blood pressure. So, response of the endocrine system. When blood pressure increases, you release AMP. When blood pressure decreases, you release a hormone that is called antidiuretic hormone. Like if you are dehydrated, you go and pee less because you are releasing ADH, which is also known as vasopressin. This one is released by the hypothalamus. And then renin, this enzyme is part of the RAAS system, renin-angiotensin-aldosterone system. So renin is going to break down a polypeptide that we have in our blood that is called angiotensinogen. And angiotensinogen is going to be converted into angiotensin 1, and then angiotensin 1 will go into the lungs, and we have an enzyme there that is called angiotensin converting enzyme. And then angiotensin 1 is going to be converted into angiotensin 2. That angiotensin 2, it will make your blood vessels to become smaller, but also is going to lead to the release of aldosterone. And aldosterone is a hormone that makes your kidneys to absorb sodium and water and eliminate potassium. So you increase sodium levels and then water levels with aldosterone. And that's supposed to increase your blood volume and your blood pressure together with the action of angiotensin 2. So here is the table showing you all of these mechanisms that helps for blood pressure maintenance. So what hormones affects peripheral resistance? Epinephrine, norepinephrine, angiotensin 2, because they vasoconstrict the blood vessels. That increases peripheral resistance. And then your renin indirectly leads to the release of this angiotensin 2. And now your nerves during the sympathetic system basically increases peripheral resistance. The decreased renin secretion and activation of vasodilation by decreasing the sympathetic system outflow when you activate parasympathetic system leads to vasodilation and decreased blood pressure. All these hormones, thyroid, epinephrine, norepinephrine, affects heart rate by increasing heart rate and force of contraction, while these other ones, atrial natriuretic peptide, decreases heart rate and in sympathetic system activation and decreased activation of the parasympathetic system. The sympathetic system. Factors that affect blood volume, the same hormones. Angiotensin indirectly makes aldosterone to be released. And if you don't drink as much water, of course, that affects also blood volume. If you have hemorrhage, that decreases blood volume. So those are factors. If someone has problems with the kidneys, like renal failure, the person will increase water retention. That increases blood volume. Sometimes you can see situations that are odd, like if someone has renal failure and he goes to the hospital, why will someone indicate to put blood volume, or not blood volume, indicate a solution that it would be good the amount for someone who has no problems with the kidneys. So you can end up adding extra liquid to someone who cannot eliminate that liquid or that volume. And then AMP and decreased retention of water can lead to decreased blood volume. Hypertension, it's basically reading twice at different times, blood pressure of 140/90. And can be classified as acute and chronic based on time. Acute is short term, long term is basically for months and for life. Based on cause can be classified as idiopathic or primary and secondary with a cause, and that cause depends. And 20% of the world population now has hypertension. That's 1/5. So out of one adult out of 5 will have hypertension. This is sad because that leads to a lot of problems with the heart, with the kidneys, and many organ systems. So we have a subclassification for blood pressure. We can have prehypertension. Someone can have a systolic between 120 to 139 and a diastolic between 80 to 89. Stage 1 hypertension is when someone has between 140 to 159 and 90 to 99 of diastolic. Stage 2 is increased blood pressure greater or equal to 160 for systolic and greater or equal to 100 diastolic. So which one is more severe? Prehypertension, stage 1, or stage 2? Stage 2. It can lead to stroke. The blood vessels in our brain can rupture. Essential accounts for 95% of the cases, or primary, the one where we don't know the cause. And only 5% is secondary. It can be narrowing of the renal arteries, which is called stenosis. It can be perhaps a tumor that secretes epinephrine, or it can be related to drugs as well. If someone takes methamphetamines, cocaine, drugs that increase the blood pressure, the person will have high blood pressure. Lastly, we're going to talk about modifications of factors. Some people, they have genetics for having hypertension. This is a non-modifiable factor. Age as well. As we age, our arteries become harder, so they are less distensible. That increases the blood pressure. That's a non-modifiable factor. Modifiable factors that can help to reduce the blood pressure will be cessation of smoking, weight loss if needed, limiting alcohol intake, increased physical activity if the person has sedentary life, dietary changes including decreasing salt intake, because salt will make the person have more blood volume, decrease intake of animal products, especially if they are high in cholesterol, and then decrease intake of saturated fats. Drug therapy is one of these last resources. It cannot be a substitute for making these changes, so don't think that the pills do a miracle. People has to do their own work as well to improve their health. And then targets for modifying blood pressure includes inhibiting some enzymes, like inhibitors of angiotensin converting enzyme, like captopril and allopril drugs, calcium channel blockers, maybe something that makes the person to urinate more, like diuretics, and sympathetic receptors on the heart, like propranolol, metoprolol, those are drugs that can decrease blood pressure.